to start by, first of all, welcoming everybody to what we're calling the COVID-19 Phase 2 webinar get-together, and very much Phase 2 as opposed to not second wave. That would certainly be an appropriate language. I do hope that everyone on is well and healthy personally, and that your families are doing well. And just a couple of administrative notes before I go ahead and introduce myself and Shai. We are going to be recording this session, so just that everyone should know, and we will do a Q&A at the end. We have somebody on who's going to help with the moderation of the Q&A, so you can put questions into the Q&A window, or the, I think that's the preferred place, or the chat window, barring that, and we will come back to them at the end. And just to, this is obviously a free-flowing situation, and this will be a bit of a free-flowing conversation. Think of this more as a fireside chat that is being brought to you, obviously, by the good folks at Medorion. And let me introduce myself. My name is Michael Laskoff. I have the great privilege of being an advisor to Medorion. But I've also, I had a history before that. I have been in telehealth, specifically behavioral telehealth, for about 12 years. Back in 2008, I founded a company called AbleTo, which is, I believe, safe to say, a pioneer in the behavioral telehealth space in particular. So I've been working virtually, starting companies virtually, creating large networks of providers virtually, and making sure that care was offered in that fashion for a long time. AbleTo, my first of the telehealth company, was recently, I think it's easiest to say, was purchased by Optum United. And in addition to the work that I do with Medorion, I advise a number of other population health and telehealth companies, both in the US and in Israel, some of which are companies like Wealth in California, Way Forward here in New York, Care Tribe, and Equip Behavioral Health, which actually focuses on the eating disorder space. And I've had the great privilege of working with Medorion now for probably about 2 years. And I've always been obsessed, actually somewhat fascinated, by how Medorion is bringing together patient data, real high-quality behavioral health science, and population-based healthcare modalities to allow for individuals to be reached in a way that will improve their engagement over time. And I have the great privilege today of being able to participate in this conversation with Shai, who is the co-founder and vice president of product for Medorion, and also, frankly, one of the great engineers that has been thinking about this problem for a long time. And Shai, like me, isn't new to healthcare. He's been involved in this kind of population health approach for about 10 years. Prior to this, he launched DB Motions, a population health analytics solution, which was then purchased by Allscripts, and he took that same notion and actually ran it to a very, very large foundation throughout the United States. And we're very, very fortunate to have him here today talking about what he has seen as Medorion has in fact been working through with its own clients across the US of different sorts, to hear about some of the things that he's seeing and learning. As you can imagine, Shai and the whole team at Medorion have been very, very busy at 2020. But before we kind of dive into the conversation, I just wanted to set the stage briefly. In some ways, this is sadly a little bit humorous, because we started thinking about this conversation a month ago or so. And we had assumed that by now we would be seeing some return to normalcy, some ways that we would be getting back to things that they were beforehand. And to point this out, we thought we would go back and we would look at some of the work that came out of University of Minnesota a few months ago about the 3 possible ways that this, in fact, would manifest itself. And I'm going to try to advance this screen. And by the way, I did fail to actually put up our charmingly good-looking pictures beforehand. I hope you will all forgive me, but you can see what Shai and I both look like on what's supposed to be our best days. But I wanted to spend a moment actually going through those 3 scenarios. just because I don't want to say that they're humorous so much as it's amazing how we got this wrong. Again, this is all work that came out of University of Minnesota's Infectious Disease and Research Center, and you can see how we thought that we might be looking at a very large peak this spring that would then kind of fall off, and then we would be looking at regular oscillations over the years. And I think, unfortunately, what it's safe to say is in order for that to have happened, we would have had to have, at least in the US, we would have actually had to have the peak end at some point, which we've obviously not seen. I think what this second scenario, the fall peak, is something that we sort of live in great dread of, except we never saw that fall off period in the middle. We're still rising, and we have no way of knowing what post things will look like after the flu season. And so that's something that has given, I think, gives a lot of thought and pause. And finally, there was the sort of fantasy of the slow burn. And the slow burn was we would have actually been over the worst of it by now, and it would just be oscillating. And this is the reason I think that this is so scary is I think we feel like we've seen this kind of possibility emerge in other parts of the world, only to be disappointed. And Israel, as Shai was alluding to, may in fact be going back into lockdown. Melbourne, Australia, all 6.5 million people there are back in lockdown, and the state of Victoria in Australia is locked down. And just to remind everybody, Australia was considered maybe not the greatest success, but a relatively great success early on. So we don't really know where things stand. And in fact, the reality here, at least in the United States, and this is as of Monday, so if we'd updated it yesterday, it would be, or today, it wouldn't be terribly different. What I think is frightening is that we had a sort of plateau, and then we headed right back into another peak. And now we have this sort of odd regionalism that's emerged. So I'm here in New York, where on Sunday, we reported our first day with no COVID deaths, which was very exciting, making us very, very different than the kinds of things that you're seeing in California or Texas, Florida, Arizona, where you're seeing radical climbs. And for those of you who can see, in Texas, what's really terrifying about that is you're not even seeing on Texas a peak yet. It's still clearly moving up and changing lots of things. And you can all read about this, and you will have read about this, but the idea is today we want to actually spend some time not focusing on slides, but actually getting the benefit of Shai as he represents Medorion and talk about how he's seen people, his experience of what he's seen people doing as they're trying to move through this specifically. And it can be a broader discussion if you have questions, but really focused on explicitly Medicare, where we're seeing all kinds of new and interesting things happening there. And with that, don't be alarmed. I'm going to stop sharing, and hopefully we will go back to a view where you will primarily see Shai and me, and hopefully we'll get that right. And you'll bear with us on the technology a little bit here. But I think we should be in pretty good shape there. So welcome, Shai. Thank you for—
Hey, Michael. Thanks for having me.
It'll be good. We're looking forward to this. So I thought we would just jump right in, because again, we want to be sensitive to people's time. So just to, and for everyone, we're going to try to cover just 4 or 5 topics. We'll spend maybe 5 minutes or so on each, and then we'll sort of see where the discussion takes us. And again, don't forget your Q&A button, your Q&A and comment areas, such that if there are questions that you want, type them in and we will return to them. So just looking back, Shai, to May, where we had about 27 million households lose employment, and those numbers have rebounded slightly. But about 80% of people who were losing their employer sponsored insurance found themselves in public plans. Obviously, the largest percentage of that is not going to be of an age where Medicare Advantage is appropriate, but it is going to be for a relatively large number. And I wanted to maybe just start a little bit with, can you talk about how that is changing the Medicare market or the Medicare Advantage market today. I mean, normally this would be a pretty quiet time of year. What's going on now?
So obviously, of all the people that have lost their jobs, there is a certain portion of the population that is Medicare eligible. And usually when we see a lot of the work and the traffic going on in Medicare, or especially Medicare Advantage around AEP and OEP, what we've been seeing is that—
And just AEP and OEP, just for those who might not know.
Yeah, annual enrollment period and open enrollment period, where basically members that are already on a Medicare Advantage plan can elect to switch their insurance provider. And that's where basically most of the acquisition and retention efforts are going on. What happens now is that as people begin to lose their job, these Medicare eligible people begin to lose their job, they have the opportunity to choose a special enrollment period where, you know, they can access their rights for Medicare. And what used to be like a relatively calm period of time, I think we're seeing today more than double the special enrollment period rates than we did same time last year. And I think if you're thinking about the state of things and the financial challenges that organizations are having, if we're trying to predict where this is really going to go, I think as we go towards a year from today, if the rates of daily infections that we're seeing today, more and more organizations are going to start to struggle financially. That means more and more people are going to begin to lose their jobs. This means that this special enrollment period that we're seeing, which was traditionally a very small market in the Medicare Advantage acquisition situation, is going to be actually a very big thing. That is what we're seeing.
So Shai, let me stop you there for a moment. Even forgetting a year from now, if you weren't expecting a doubling of this special enrollment period, were you, first of all, how are health plans, how are they transitioning into handling that? Has that been something that's gone relatively smoothly for people? Is it something that caught them by surprise? What are they having to do, in other words, to actually get themselves ready just to handle the current surge?
So I think the first thing, like everything around COVID, it caught everybody by surprise, right? And initially, you could see some things through the data. And we were able to see with various health plans a correlation between the drop in group coverage and the same peak in people losing their jobs. And then everything kind of clicked. What are we seeing? Are we seeing disenrollment, or are we seeing people losing coverage? And I think that sparked two things to happen. One is to try and address the special enrollment period. And the second, and I think a bit more challenging one, is how do we identify people that are likely to be in this situation, right? How can we find out who's eligible for the special enrollment period and who needs help with figuring out what to do with their healthcare right now?
So so talk a little bit about that one, because I would imagine it's, we've all been through the overwhelming change in life that that COVID brought, and that's for those of us who are lucky enough to have retained employment. For those who didn't, it's been even more overwhelming. How are health plans? So when someone is losing their job and therefore losing coverage and becomes Medicare Advantage eligible, they may have been beforehand, but how are plans thinking about finding those people?
I think this is actually an area where you need to be a little bit creative of how you use your data, right? Because there's no like data flag, or there's no, somebody raises their hand and says, I need Medicare Advantage right now. Sometimes it comes as a surprise. And I think one of the creative ways that we've found out is for health plans to look at their group coverage and to identify their Medicare eligible population, and to identify people that have suddenly dropped their coverage. And it's either one of two things happening. They're changing their employer, right, which is less likely to be happening right now, or they're losing their job and losing their coverage. And I think that's a pretty easy way to use your data to identify people that are eligible for the special enrollment period, and to really refine and target them and help them out.
And can you expand on, just before we move on, expand on that maybe just for a moment? So the the way that you may know somebody has an issue in terms of lost coverage is effectively that member in effect disappearing. Now, once that happens though, does a health plan retain the right to communicate with that person? And if not, how is the health plan able to reach out? You mentioned it's important to be creative. How are some of the creative ways that people are reaching out?
Right. So I think in terms of the eligibility to reach out to members, again, it falls under several clauses in HIPAA to reach out to members and to explain to them about their products that health plans sell, especially around Medicare Advantages, or Medicare is one of the examples that HIPAA explicitly calls out, is something that you can do in order to help members retain their coverage and provide them with healthcare services that are relevant to them. And so you can definitely reach out and engage those members. And I think some of the ways, right, if you try to step into a member's state of mind, is that they might have had a crash course in retirement. Like this wasn't what they were planning. Usually retirement is something well thought out that has a process to it. And now they find themselves in the situation where they need coverage and they have a crash course in retirement and in Medicare specifically. And that's, I think, where health plans can be creative and what do you tell them and how do you help people?
Okay, and so perhaps my guess is there'll be more questions.
So I think we might have lost Michael. If anybody in the participants can still hear me so that I know that we've lost Michael and not myself. If you want to ping in the chat that you can, okay, great, you can hear me. Thanks everybody. So that means that we've lost Michael. And until Michael pops back, maybe I'll talk a little bit about, oh, Michael, you're back? I was just
sorry about that.
Buffering a little bit. Go ahead, we can hear you now.
Good. My apologies, everyone. The problem with working from home in New York City is in my neighborhood. This is about the time of day where I think usage surges. So we were just going to go on and actually open up to a different question and move a little bit to talking about elective procedures. I was actually reading just in the Washington Post yesterday, or it may have actually been today's piece, that elective procedures are down as much as 80% in many places. And we know one of the obvious downsides of that is that it has in fact put enormous stress on many doctors who ironically don't actually, whose practices are now in danger, but it's also has real impact for patients. The definition of what is elective can be pretty broad, and that can be obviously everything from patients who are living with, who need hips replaced to, frankly, unfortunately, people who might need cancer treatment ongoing. One of the interesting issues at this point is that you have people now who are afraid to go to the hospital. Is this something you're seeing? Or are your clients seeing? And if so, what kinds of strategies are they using to help encourage people to return to the kind of care that's actually critical to their long-term well-being?
Right, and I think that's definitely things that we're seeing there. If some health plans aren't reaching their MLR rates and need to return, some of the premiums back to their members, and this is, coming from a position, like you said, it's not a very positive position. It means that people aren't getting the care that they needed. And I think initially, if health plans thought, we'll wait this COVID out maybe 2-3 months, and then we'll go back to engaging the population with the elective procedures that are recommended, like mammography, colonoscopy, diabetes eye exams, things like that are very beneficial. And we've, given what you've just shown around the peaks and valleys and the lack of valleys and barely plateaus, I think health plans are starting to see that, with half a year almost gone, there are a lot of people that are going to need to catch this stuff up, and starting to think about, taking all these initiatives that were initially frozen at the beginning of the year and then repurposing them and finding creative ways to get people back into the care that they need in a safe way.
Can you give an example of where maybe you've seen that, an approach to that you've seen that's working?
Yeah, sure. I think, first of all, what we're seeing is health plans the first thing that they need to do is to think about what do they want people to do, right? And then I'll walk you through a couple of examples of how they're trying to execute that. And so, the key go-to things is, what do we want people to do? You can look at your HEDIS measures or your STARS HEDIS measures for your Medicare Advantage plans. And for people that don't know, these are clinical KPIs that are tied to preventive medicine, specifically around colonoscopy, mammography, diabetes eye exam, which require members basically to usually get out of the house and get care, whether like it's a colonoscopy. And then first of all, identifying what they want to do, what their current gaps in care are, what their levels are, and where they want to target, their scores this year, or what percentage of the population they want to have completed this elective surgery. And then they can get really creative. Cool examples could be around, instead of advocating for colonoscopy, plans can advocate for, home stool testing. It's something that has a quick pick up and drop off, very limited impact on member engagement with, the outside world. It could even be home delivered in some cases. And then for positive cases of the stool test, then elect for colonoscopy. There are many different ways to do this, even without bringing members into situations where they feel that they might be at risk. But I think, that doesn't work in all scenarios. And there's also ways that health plans can encourage members to get elective surgery, even if they are afraid.
And how might a health plan engage? How might they set up a dialogue to help direct that kind of requirement to get back out to get the kind of health care that they need?
So I think the first thing is getting this as part of a member's sense of urgency, right? Because members are hearing COVID from everywhere they turn. And, cancer is still there. And especially for our senior population, early detection for cancer can be a big factor in mortality rates and in future quality of life. And so just to bring that up is the first thing that health plans can do. COVID, yes, but also cancer. That's the first thing that health plans can do. And the second thing, I think, is to bring back that dialogue between members and their physicians, and get members to ask physicians, two questions. One is this the right time for me to have, to come in for an eye exam, to come in for mammography? And then the second question is, how can I do this safely? How does it work? And let the providers bring that sense of safety to the members, walk them through how they can get the care that they need in a safe way, and basically reduce that fear that they have. Break it down into, something that members can process and say, okay, well, I understand the risk now. I understand a good way to do it. And then they can make, the educated choice to say, yes, okay, now I want to participate.
Okay, and is that something that you're seeing? And then before we, so there is a need, obviously, to get people out there for elective procedures. One thing that I think you brought up, but which is a really excellent point, is that for population health metrics for which providers and health plans might be measured, they're still being measured for those things.
Yeah.
And so it is important to do that. And just to recap something you said, it sounds like one of the things that a health plan can do to be really genuinely helpful is to be communicating with its own provider groups, or the provider groups it works with, to help encourage that discussion with patients. So are you actually seeing that happening from the health plan, or are you seeing that happen from the provider side?
I think we're seeing it happening in both settings. I think health plans are definitely talking to providers, but I think the setting that is more interesting in this case, and you spoke about the members' fear, is in the health plan's capability to engage the members and to persuade them to talk to their physicians, right? I think if the first thing that a member needs to know is that, again, that cancer hasn't gone anywhere, and that early detection is key, right, for this age group, and that reduces the risk. And then the second thing is go talk to your doctor again. Ask them if this is the right time to get screened or to come into the office, and then ask them how that process is done. As a provider, how do you keep my safety? And by opening this dialogue, they'll regain that trust they had with the provider, right? And then they'll make their own choice to opt in to say, okay, so I'm going to choose to do this procedure,
Okay.
right? And
well,
put that on the member to communicate, right?
Oh, it's a really interesting question, though. And I just reflecting on my own experience, I've been doing, as I mentioned, telehealth for about 10 years. And one of the biggest challenges that we had, that AbleTo has had historically, and I think most things, is actually, you're effectively talking about changing member behavior in two really important ways. So it's bad enough simply to say that you should, for example, have a colonoscopy, because no one really wants to do that. But it's also really incredibly difficult where you're saying we should change the tenor or the format of the relationship that a provider is going to have with you by doing much more kind of remotely from a telehealth perspective, such that you might, instead of going in seeing a physician, for example, say, and having that physician say, you need a colonoscopy, and then you might go and get a colonoscopy, and then you would come back to that same doctor. The idea that you're going to move all of that from a sort of maybe inconvenient, but a terribly like comfortable sort of like pathway for getting care, and changing it such that all of it is going to, is most of it, or as much as possible, will be happening in a telehealth environment. How do you advise your clients, the folks that you're working with, on how to help people make that kind of transition?
Right, and I think it all starts with understanding your member's disposition and barriers to action. And you mentioned fear as being one of them, right? And if you're talking about colonoscopy, there's a bunch of fear associated with that even before you start to think about COVID, right? You know, you could be afraid of the procedure or just afraid to find out that you have cancer, so you don't want to get screened. There's a bunch of barriers to action or underlying inhibitions that members have. And then you add COVID on top of that as being, you know, afraid just to get sick while you're doing that. I think what we're trying to advise health plans to do is to find out ways to understand your members' barriers to action, really at the member level. Be able to differentiate between, you know, me and you. What are your barriers to action? What are my barriers to action? And then tap into each person's barriers to action and address those, right? And try to find ways to do that at a large scale. Otherwise, it's going to be very hard, you know, from a population health perspective, to motivate all these people to move such, you know, the needle at such a large scale.
And jumping right into the meat of it, gee, that sounds like a wonderful thing to do. I would love, as a health plan, to know each one of my members individually, but is that really practical? I mean, you've talked about two things. You've effectively talked about understanding someone's sources of fear, or which kind of implies something about their emotional state as to why they will or won't take an action. And then actually proposing a response to that. Well, if I've got to reach 100,000 or 500,000 people, how do you do that practically?
So I'll talk about it at a really high level, and if we want to, we can dig into it. I think there's three key things that you want to do. The first thing is you need data, right? The data that you have about your members, your claims data, is really what's going to, you know, if you use that correctly, you can find out a lot about your members, including barriers to action. But the first thing is you have to be able to access that data quickly, right? And then be able to apply it quickly. So there's some integration and IT behind that. The second thing that you mentioned was to be able to reach out to, you said, you know, 500,000 members, right? How do I do that? There's a lot of marketing automation involved there. Tools that send out emails and messages on social media and text and put members on journeys that help persuade all these things. That data topic and that marketing automation topic, those two things are areas where there's a lot of software solutions and integrators that can help. But I think the key in the middle is how do you use, you know, the connecting between the data and the journey. That the key there is how do you use the data to be able to understand a member's barrier to action at scale, right? 500,000 members, use their data, understand what their barrier to action is, and then make sure they get the right email, right? You get an email talking about, you know, the cost of, you know, picking up your drugs, and I get an email that talks about, you know, working, you know, to figure out a way to reduce the side effects that I have. And we both get different emails. And I think that area, understanding barriers to action, using data, that's where most of the focus should be. That's where a lot of the technical challenges are.
because that doesn't sound at all logical to me. What sounds logical to me is that I've got a bunch of data, maybe about what kinds of tests people have had when they've been to the doctor. I don't have anything about their emotional state or what motivates them. So talk a little bit more about how you go from the kind of data that I might as a health plan actually have to the rather large leap in my head of what you're talking about, which is how do you know something about like how you go from there to understanding what affects an individual's propensity to take action or not take action.
Okay. So if I go too geeky, stop me. But let's take a look at the claims data. Claims data is very, very wide as it collects a lot of data elements, and it's very, very long as it has hundreds of thousands, millions of members, right? So this is a classical solution for AI. AI will be tasked to sort through the data and figure stuff out, figure patterns out. And you could ask the AI to predict, right? Who's going to have a colonoscopy, et cetera, et cetera. And I think that's the first stage. But if you think about it, it's not enough. Let's assume that you know that I am unlikely to have a colonoscopy. If you're trying to persuade me to have a colonoscopy, you know, how does that help you? So you know that I have one of 10 barriers to action. So the way that we're approaching this problem is data is very, very helpful and AI is helpful, but it's not enough. Another discipline that we've found as being helpful to use data to actually understand what people are thinking is in the behavioral science. And you kind of touched a little bit about that in the beginning of our conversation. The behavioral science has models that by given specific data inputs can say, well, you know, here's where a person is in the state of adopting cancer screening. And so what we've found is the combination between AI that says, well, these are the predicting factors of, let's say, Shai's behavior, applying that into the right behavioral science model will say, well, that's because Shai is afraid of finding out that he has cancer. And when you know that across, you know, hundreds of thousands of members, you can identify a segment of members that are afraid to find out that they have cancer. Now you can use your marketing automation tool to tell them, well, you know, people get screened and only a small percentage of them actually have cancer, right? So get this done, get your peace of mind. Now you're talking to the member's specific barrier to action, and your probability of changing behavior is much higher.
Okay, so you're not suggesting that that health plans go out and do specific survey data. You're actually saying they have enough data currently that when properly analyzed would allow them to answer these questions.
Yes, yes.
Okay. Sounds great. It also sounds very, very difficult. So how do you do this on a scaled basis? Because I understand what you just said. So you could look me up and you could take my profile and you could determine that I've had a colonoscopy, I can tell you that I'm afraid of having another one. You could put me into the right kind of category and you could actually tailor a message for me. How do you do that for everybody? So you talked about the idea that you can do, if you could do that for everybody, then you can use marketing automation tools. But is there a disconnect in there between how you do it for one person and how you do it for everybody?
Right. And so I think the first step we talked about it is being able to access data, right? Have a solution that constantly feeds claims into your AI. The second step would be having your AI predict who's going to do something or not do something, right? That's the basic, that's the first step. And then the correlating data elements that help the AI get to this decision, right? And then on top of that comes your behavioral model, which says, well, given these data elements and this action, here's what the model says the member is thinking, right? And that runs across, you know, hundreds of thousands of members and comes back and says, these 30,000 fit this template of the algorithm. Those 70,000 fit this template of the algorithm, right?
Okay.
And
so
then,
as long as you can work with a marketing firm that can actually take that information, you could therefore tailor different messages to them.
Yes, it would basically create a segmentation, right? A set of people that have the same characteristics in terms of the data that is, it's not just the data that's predicting them, because we can both be afraid of finding out we have cancer, but have different data elements predicting that, right?
Because we have different reasons for being afraid?
Yes. And there are different signals in our claims that highlight that out. And that's where the behavioral science basically says, we have different claims, but might have the same barrier to action. That's why you need AI. It's not like a simple rule-based solution.
Okay.
That's where the AI really comes in. And then, like you said, the integration into the marketing automation, you say, okay, so now that I know these people have this barrier to action, I can plug into the marketing automation and send them an email that talks about the specific barrier to action and what the health plan recommends doing in that scenario. And I think the final part would be to measure members' reactions to that. Did they open the email? Did they click on it? Did they eventually complete the procedure? Or pick up the drug that we wanted them to do? And that feeds your AI again and helps the AI improve.
Okay, and
classification.
I'm going to flip this a little bit to, by the way, for those of you who are been so incredibly good and patient to participate in, I did want to apologize for my little drop off there. I wanted to actually flip this a little bit to fall because it raises a couple of really interesting questions. We've been talking about all of this from if you're a health plan member, and I can know a lot about you and I can do this kind of messaging. But come fall, we get back to open enrollment season, which is very much like, I think, what you were describing also previously, of this notion there are a lot of people out there who I don't necessarily have a relationship with yet. How can I communicate with those people? If I need data to drive things, beyond knowing that someone is available, is there data that can be, for example, that you can derive from some non-claim source that can make me able or work with a plan's health marketing partner to make it more effective to reach out to people? So if there are 10,000 people now in the area that I cover who no longer have insurance, can I go to the market and buy information that will make me more likely to connect with those people?
So the answer to that is yes. There are quite a few ways to do that, where you can acquire basically a prospect list, right? And go on and say, I want everybody living in state X or in these counties where I prefer to operate, and have them be 65 plus. And then you can actually append a bunch of data elements to them, like marital status and a bunch of social determinants of health. I think that's a great way to get started around understanding your prospect market and being able to, understand them in terms of like health literacy, et cetera. But I don't think that that's enough. I think you can do more.
Okay.
And talk a little bit about that. If you think about it, your plan probably has, we just said, hundreds of, thousands of members already on the plan. And what your data will tell you is which of these people, if you use it correctly, right, which of these people chose which plan that you have and why.
Right.
Right. And we've seen patterns in our clients that, diabetics buy plans that are different than people that are healthy, obviously, or other people that have different comorbidities. And if you understand why they're doing this, as you engage your prospect market, you will be able to highlight plans or highlight decision processes that your members have already had and say things like, our diabetic members love this plan because A, B, C, D. You don't need to know that your prospect is diabetic, but you already know the thought process of a diabetic as it applies to your specific plan. And when you have...
let's go into that in just a slightly different way, because whether it's your data or data that you're bringing in from the outside, you talked about the importance of measuring outcomes, frankly, which is to say that you want to use this because you want to make the AI or the machine learning capability that Medorion is using even more responsive. As you're doing that, if you discover it seems that one of the advantages, if you're doing all of this electronically, all the marketing is being done electronically, that you should be able to pivot more quickly if something doesn't work. How do you recognize, or can you give an example of where you've recognized or where you've had a client recognize something that has not worked and then pivoted to something that does work better?
Sure. So part of the way that when you engage members via email, part of the feedback that you're getting is at the member level, right? So, you know, Shai opened an email and Shai clicked on this link or that link. And the other things that you know about Shai is either their social determinants of health record, if they're a prospect and you emailed them, or that they're one of your members. So you know their entire clinical history. And you can begin to correlate using AI their claims or clinical data and how they're engaging with your email and what they're engaging with your email. And we've been able to use that to understand amazing things like what is the exact sensitivity in terms of income where members change plan tiers. They'll go for a higher tier or a lower tier. Or what are the comorbidities where members will prioritize their health over cost of a plan. And they'll say, well, you know, we'll opt for a more expensive plan, even if our income is lower than the other, you know, average population buying this plan. So you can identify very, very refined sensitivities of why members are doing what they're doing. You understand their thought process better. And then you can actually apply that to your prospect market, to people that you don't know anything about. And you can say, if you're managing multiple ongoing chronic conditions such as hypertension and diabetes, this plan might be for you. You already know that you have tens of thousands of people that have done the same decision in the past. Now you're much smarter in the way that you're engaging your prospects. I hope that came out better.
I think the idea is that you can find something that it's important to say that you have a strong thesis that no one can know for certain what precisely will work. But you can get rapid market data feedback now in a way that will say, well, if that isn't resonating, let's go to the next, to the next position.
Exactly. The way that people engage with your emails will tell you that your assumption was wrong. So you will say, I expected people to engage with a message about doctor continuity, and instead they're, you know, people similar to them are engaging with messages about, you know, RX copays. Whoops. So I need to pivot to RX copays. Why is that happening? Okay, understanding the cost behind pharmacy. And then you can, you know, say, oh, well, these people are actually cost sensitive. It's not just the pharmacy. Now I want to talk to them about copays, doctor visitations, right?
Good.
You're learning from the way that they engage with your messages.
Last question, speed round, because the timekeeper is reminding me that we're going to get to the Q&A in just a minute. Fall is coming up. Are there any like words of wisdom or advice that you have for people in terms of thinking about what their priorities should be this fall?
Okay, so speed round, I think going to look back at AEP, revisit AEP. The reasons around AEP are going to be different. People are, instead of saying, I'm dissatisfied with my plan, they're going to be thinking, you know, why should I switch my plan now? You know, with all this risk. And then you can flip that both for retention. You can tell your members, stay with me, why switch now? You could also apply to prospects. Hey, we're market leaders. Here's why you should switch to us. You're going to have a lot of new members around that had special enrollment period. You're going to want to embrace them so that they don't leave you in AEP. And they had a crash course. Remember, they had a crash course in Medicare. And they don't know the ropes yet. They haven't had time to think about it, so embrace them. And then the last thing I think is be very, very agile with your elective procedures or your, I would say, HEDIS measures, whether it's pharmacy or elective procedures or, you know, just med adherence. And be very, very nimble in, you know, if there's really this, you know, valley, right? Now's the right time to send people to elective procedures. If there is no valley, be creative and use, you know, stool tests instead of colonoscopies because they're safer. You need to think out of the box and utilize the opportunities that are happening during the fall and be very, very nimble in the way that you engage your members and what you're asking them to do.
Great. And flu shots. Everybody gets flu shots this year, right?
Yes, of course, of course.
Well, first of all, Shai, that was great. Thank you. And again, apologies for my little technical snafu. And thanks for Shai. Just to keep it more interesting for everybody, we'd worked out this careful script and then I didn't use it just to keep Shai on his toes. So Shai, thank you for doing that. And as a reminder, this is being recorded and can be shared if in fact that is helpful to people. And if we don't get to all of the questions that are coming up or there are specific questions that we can't answer, we'll be more than pleased, i.e. Shai and team will be more than pleased to follow up individually. There are a few questions that have actually come up already, and I wanted to start with that of a, I would say, a distinguished psychiatrist from the West Coast who's asking about the whether or not with what we're talking about, where it's got some predictive capability in effect, you're predicting how people will react to a particular set of motivations or messages. Can this be extended into the behavioral world as well, such that there are people, for example, who might have a heart condition, who may also need treatment for depression? Have you seen cases where your clients or Medorion in its own work separately has done things on the behavioral side as well as just the medical side?
The answer is definitely yes, because if you think about it, bottom line, all the behaviors are mostly the same. You want your member to take a specific action, right? And that could be get screened, pick up your drugs, enroll in my plan, or stay with me in my plan. And the same thing is, consume services around mental health, right? Or health behavior. And really, each one of these have, all the fundamentals that are required to do this. One, there's the claims data that shows you who needs to do this and who's engaging with it or disengaging with it. And they all have behavioral science models which say, well, given these data elements, this is what behavioral science says is this person's barrier to action. So if you think about it, it all follows this model. Put in the right claims data, use the AI, feed that into behavioral science, and it'll tell you these people aren't engaging with this service because of reason X, and these people aren't because of reason Y. So it all fits, the same template.
Are there people, though, who you would then actually go to the next stage and say that, gee, while we're doing this, it seems that this is an individual who is consistent with someone who might benefit from a behavioral intervention? And if you haven't, that's fine, because I think this is really new and cutting edge. But if not, is that something that you think is that possible? Is that something that would be interesting to pursue?
Yes, I think the way you kind of want to look at it is a lookalike. So let's say you have 10,000 patients or members that are associated with, having been treated in the past, and they have a certain pattern of consuming healthcare or not consuming healthcare, right? And you will task your AI to say, find people that look like these, and the AI will find them. I think the next step is you have to be very, very sensitive and ethical in the way that you engage these people. You have to be very, very sensitive, because to come and say, you might be suffering from depression would be very, very aggressive and invasive, right? Even though your indications that they might be suffering from depression are high, right? And so this is where you have to think about your strategy and how you want them to begin to think about this, and how you bring this topic up with a conversation with them, whether it's an email or social media or whatever way that you engage or channel that you engage your members. You want to be able to bring this up in a subtle way where, the member can elect to say, I want to hear more. And that right. would be your hook as a health plan to continue the dialogue with them. So that's where you need to
it wouldn't be like, here's a coupon for Red Lobster if you go and get this sort of thing. It would be a very much more subtle and tailored sort of beginning of opening of a pathway. But the same approach that you use to encouraging other kinds of proactive health, you could frankly use to perhaps say, it would be the right way to start a conversation with such an individual, with the intent being that it arrives someplace else. That would be the kind of approach you would take, as I understand.
Yes.
Okay. Can you go back for a moment and talk just a little bit of clarity? This another question is, how do you use behavioral data to also to determine a behavioral state, and or the kinds of, and I think it'd be interesting for you just to talk for a moment about how you use this blizzard of data, because you mentioned it's both wide and deep. It can be go back many years, can have many data points. How do you figure out, how does the organization determine what's most valid, how to apply? Can you just speak, and keep in mind that, like, I'm a layperson, so this will have to be a really, a simple answer, but how do you figure out what's valuable and what isn't in that data?
Great. I think one of the models that we can talk about, so if you think about AI being a machine, it'll just say this person is not likely, let's say, to undergo a colonoscopy, right? And these are the data elements that are correlating to it. One, lack of history of any cancer screening in the past, and two is their specific age. right? That's what the AI is saying. That's why I've come to the conclusion that Shai is only 30% likely to have a colonoscopy, right? When you feed that into the relevant behavioral model, it'll tell you a lot more about Shai. So the behavioral model that's relevant for cancer screening is called a precaution adoption process model. And part of what that says is lack of history and, let's say, a relatively young age is a very good indicator of one of two things. Either the person doesn't understand the guidelines, they're not aware of the guidelines. What do you do? What are you eligible for? What's covered, et cetera? Or they don't even understand their sense of urgency, right? And then this radically changes, right? With the model that says if the person is like 65 years old, the model will tell you there's no way that this person doesn't understand the sense of urgency, right? Because historically, if you're 65 years old, you already know somebody who had colon cancer, more than one, right? And you've known people probably that have died from it. So the behavioral model will use that data and will tell you where the person falls in. So it's not clear cut, the AI's results, it's not clear cut. The behavioral model will provide the clarity of why it classified this person into this category.
Okay. That's the kind of thing that for anybody who wants more information as to how Medorion does it, I can assure you it's like a 3-hour conversation. It's actually fascinating. But I want to end on a last question, which is somebody comes back with a very pointed question, which is to the effect that if you wanted to, what would you recommend to plans that are concerned with saying for COVID, here are the people who are most vulnerable that we need to get appropriate care to? Can you give just a point of view on how you might go about thinking about who those people would be, how you'd work with a health plan, and then what kind of communication approach you would recommend taking?
Right, and I think if you think about the population health pyramid, right, at the very top, you have the people that are the most sick and the most susceptible, but they also have the most attention. They probably have a care coordinator or care manager that can touch base with them, maybe daily, maybe on a phone call, maybe even have a relationship with them, right? And that's the area where, you actually don't want to focus a lot of your efforts because you already have a lot of effort there. When you're looking at the COVID risk, basically your entire population is an at-risk population, right? And when you look at the, just your senior, right, we're talking about Medicare Advantage, just your senior population is an even higher risk than everybody else that we were talking about. So you got everybody up there. And then you can begin to stratify them by looking at things like comorbidities, right? Unmanaged chronic conditions, which will put members at a higher risk for COVID complications. And that's the things that you want to use. So if you have members that have unmanaged chronic conditions, you want to be able to increase the sense of urgency to manage their chronic conditions. See your doctor, pick up your medications, because the risk of COVID complications for you is higher, being both a senior and a chronic member. And so that you can look at your entire population as at risk and categorize them by people that are more healthy, people that have chronic conditions, people that have unmanaged chronic conditions. And then at the very end, people that, really have a very high touch care. And those are where, you already have resources applied. And I would look at the bottom of that funnel. The people that are more healthy actually need the more guidance. They're still at risk. Don't forget them.
Great. Well, everyone, a big round of applause to Shai for being the guinea pig on this first of what I suspect will become a series of quick topics that we jump into on this sort of thing. If you have follow-up questions for Shai or anyone else, I think everyone will have contact information or can reach out through the emails that they've been getting. If there are topics that you would like addressed in terms of how the Medorion approach of looking at behavioral approaches to working with healthcare populations, whether that's on the, frankly, whether that's on the member acquisition side or on the sort of health perspective of getting a population to do things proactively. If there are things like that you'd like us to think about over the summer, let Shai know, and we will come back to that. But we're 3 minutes early. We just want to thank everyone for making the time to attend today, and hope that everyone has a good and safe day wherever you are. And thank you very much for joining. So thank you, Shai.
Thanks for having me, Michael.
Bye-bye.